Morning. I'm Charlita Tavares. I'm the CEO of Primary One Health, and this is our quarterly community health advocacy breakfast forum. I hope everyone has their coffee or tea or orange juice. You can have your chicken and waffles, you can have your pancakes or a cereal or muffin, but we just want you to be comfortable as we relax and hear more from our guest speakers this morning. This morning, we're really going to tackle the subject of COVID-19, and especially in communities of color who are disproportionately being impacted by the COVID-19 virus. So with that, I'm going to introduce our guests, and there is a chat box that you can share your questions in the chat box if you have some comments. And we will have Chris Stein, who is assisting us with this morning's presentation. We will have her read those questions as they come in because I can't see them. With that, I'm going to start off with the introductions. And each of the speakers will give a presentation, approximately 15 minutes each. And if there are questions in between each of the speakers, we'll take those. If not, we'll take questions at the end. At this point, we're going to go ahead and introduce Dr. Leon McDougall, who's the Chief Diversity Officer with the Ohio State University Wexner Medical Center, the Associate Dean of Diversity and Inclusion, and the Director of MedPath Pre-Medical Post-Baccalaureate Program, and Professor of Family Medicine. He is a Professor of Family Medicine with tenure and the first Chief Diversity Officer for the Wexner Medical Center. He directs several workforce diversity programs, including the MedPath Post-Baccalaureate Program. A graduate of the University of Toledo and the Ohio State College of Medicine, he completed a family medicine residency at the Naval Hospital at Camp Pendleton, California, and earned a Master of Health degree from the University of Michigan School of Public Health. We won't hold that against you. Department of Management and Policy. Dr. McDougall has been a family medicine on the Near East Side of Columbus since 2001 and believes that lifestyle must be a focus of both the treatment and prevention of chronic diseases such as diabetes and high blood pressure. His research is focused on diversity and inclusion and eliminating health disparities. Dr. McDougall is serving as the president of the National Medical Association, which makes him a voting member of the Board of Trustees and Executive Committee. Dr. McDougall is a past chair of the Association of American Medical Colleges Group on Diversity and Inclusion, and provides service for the AAMC as faculty for the Health Care Executive Diversity and Inclusion Certificate Program and Minority Faculty Leadership Seminar. Dr. McDougall was appointed to serve as the NMA representative on the National Collegiate Athletic Association Coronavirus Medical Advisory Group in July of 2020. He is a diplomat of the American Board of Family Medicine, a fellow of the American Academy of Family Physicians, and a member of the Association of Military Surgeons of the United States. Dr. McDougall, the floor is yours, and thank you for joining us this morning.
Good morning, and thank you, Charlita. And so I'm going to share slides here. And that's okay, so our topic this morning will be COVID-19, its impact in African-American communities. Our objectives, we're going to talk about the importance of transparency in conducting clinical trials. We're also going to describe the important role of community-based and professional organizations in the times we are in now, and also recognize the importance of what we're doing now. We're having a conversation. So to begin, I'd like to share this quote from Reverend Dr. Martin Luther King Jr. I know many times we hear the first part of this quote. I'd like us to focus on the rest of the quote from his time in Birmingham jail in 1963. So we are caught in an inescapable network of mutuality. And I love that word, mutuality. Tied in a single garment of destiny, whatever affects one directly affects us all indirectly. So think about that quote and COVID-19. So, as many of you have noticed over this past year, some of the decisions being made in regards to this pandemic seem to have been clouded by political interference. And I'll just provide one example for this morning, and that would be hydroxychloroquine, how that was touted as being a remedy for COVID-19. And remember, the VA bought up half the supply and the Bureau of Prisons bought up the other half, essentially, and it just wasn't good. So that's not the way to proceed in a pandemic. And we're all realizing the importance of science and adhering to scientific principles. Looking at the data early in this pandemic, this data was not available. And I remember sharing concern with Charlita Tavares and others in the community, and also this resulting in the Congressional Black Caucus Health Brain Trust demanding this data from the CDC. The National Medical Association joined in on that demand, and you'll see here why. So what are we seeing? We're seeing that African Americans, Latinx, and indigenous populations are dying at much higher rates and being hospitalized as in much higher rates than the general public. Another fascinating aspect of this, so this was just recently published, the life expectancy for persons born who are Black and Latinx is actually declining. And for the Black population, this is after a 6-year period of where the gap between European Americans and African Americans in regards to life expectancy was actually declining. So that has been erased. And even when one starts at age 65, there's a reversal. There's a problem with life expectancy being reduced. Now, here you'll see this depicted in a chart graphic standpoint. I just wanted to show this via a graphic depiction also. So you'll see how long we were expected to live in the orange and without COVID, and the reversal in the blue. So these are disturbing data. Now, I know we've heard a lot about contact tracing, and this was a very troubling, the findings were troubling in this. So we know contact tracing is important. This is speaking to how people didn't want to cooperate with contact tracing. And in fact, you see all the demographic groups there. About 25% of folks said they would not provide, they wouldn't feel comfortable providing the names of people they may have been in physical contact with. And also the same for places they had recently visited. And then we talk about cell phone. Oh no, you can't have access to my cell phone. So see, so these are things that make it difficult for us to overcome the deaths and illness that we're seeing in this pandemic. Now, let's talk about vaccine hesitancy. Now, this is a report from a Kaiser Family Foundation survey. And yes, there has been some improvements. So for the Black community in September, 50% of those persons surveyed were willing to receive the vaccine. Now that improved to 62% in December, and the African American Black community had the highest rate among racial and ethnic groups for vaccine hesitancy. And lo and behold, look at this here in regards to health care workers. About 30% of us did not want to receive the vaccine or displayed hesitancy in its dissemination or receipt. So now, that being said, efforts have been ongoing, and I'm seeing, at least in my practice, a higher willingness to receive the vaccine. And in fact, some instances, vaccine envy in regards to having access to the vaccine. So I'll just tell a story here. So I had an opportunity to participate on a town hall with the Ohio Department of Health on Monday. Governor DeWine kicked off the meeting. We had the president of the NAACP, the president of the Cincinnati Urban League, and the director of health in Cincinnati, and we spoke about COVID-19. And the next day, I received a message from one of my patients who was 60 and wasn't in that age group that are being allowed to receive the vaccine. And she voiced concern. She thought it was unfair that her being 60 and being at high risk in general, she wasn't in line or scheduled to get the vaccine. So again, speaking to how some of this hesitancy, I think, has really started to change in the community. Okay. Now, so going back to Dr. King, he was speaking to us in 1968 in his book, Where Do We Go From Here? Chaos or Community? And what does Dr. King say when we're challenged, when there are big problems we have to tackle in the community? We need to turn to the pillars of the Black community, the Black church, Black media, Black fraternities and sororities, Black professional organizations. When we speak to Black media, when we're advertising or reaching out to community, use Black radio, use Black network opportunities to reach out to the community. And so this year has been fascinating for me. I've had the opportunity to work with Reverend Jesse L. Jackson Jr., Sr., and the Rainbow Push Coalition and the National Bar Association. In fact, we published a public health manifesto in April, which I know through the efforts of Charlita Tavares has been distributed across the network of federally qualified health centers. Reverend Jackson said, we need a 10-point plan to face this challenge. And we actually agreed to a 12-point plan. So I would recommend that y'all take a look at that plan. And then most recently, December 15th, the National Medical Association's advisory task force on COVID-19 vaccines and therapeutics released our report after meeting with the scientists from Pfizer, the scientists from Moderna. We're also meeting with the scientists from J&J, Janssen, and AstraZeneca. And in fact, we're going to be meeting with Johnson & Johnson and Janssen on this upcoming Friday, and we'll be releasing another statement in regards to that vaccine candidate that recently received approval from the FDA. So please know that that's a resource for you. And I'm about at the end of my presentation here. We're also in collaboration with the Black Coalition Against COVID. This is a wonderful resource, involves the consortium of 4 Black medical schools, Howard, Meharry, Morehouse, and Charles R. Drew, the National Urban League, the National Black Nurses Association, the National Medical Association, and the Montague Cobb Health Institute and blackdoctor.org. We've convened town halls with over 260,000 views. Those town halls and other resources are available on this website. And lastly, we're working with Congresswoman Ayanna Pressley on her Anti-Racism and Public Health Act legislation that was recently reintroduced. And I also had an opportunity to write an op-ed with Representative Ayanna Presley concerning this issue that was just most recently published in the Boston Globe. And the goals are to create a national center for anti-racism through CDC and create a law enforcement violence prevention program within CDC. So I think I'm at the end of my presentation, and thank you for your time and attention, and I'll stop sharing slides.
Thank you very much, Dr. McDougall, and thank you for the work that you're doing with the NMA and the National Black Coalition Against COVID, as well as the Rainbow Push Coalition and the NMA on the manifesto. And as you shared, we have certainly done our part to share it with as many organizations as possible. We shared it with the National Association of Community Health Centers, NAC, which is our national association, as well as our state association, the Ohio Association of Community Health Centers. And then finally, as you know, we shared many of your recommendations as well as the manifesto with the governor's minority health strike force that was put together to address the disparities amongst racial ethnic communities and cultural communities with the COVID-19 pandemic. So I thank you very much. Chris, do we have any questions at this point that?
Not at this time.
Okay, great. Well, we will move on to Dr. Mona Prasad. Dr. Mona Prasad is the Director of Maternal Fetal Medicine at Ohio Health, Columbus, Ohio. She is boarded in addiction medicine and has a national reputation in the arena of substance use and Hep C and pregnancy. Dr. Prasad began her work with opiate use disorder and pregnancy as a medical director of substance abuse treatment, education, prevention program, STEP, which was a clinic at Ohio State in 2010. She has continued this work since 2018 at Ohio Health in a co-located clinic providing obstetric care simultaneously with medication-assisted treatment, both in pregnancy and for the first year postpartum. Dr. Prasad has significant experience in quality improvement, having completed I2S2 or 1-2S2 training, and she has applied that knowledge both with the Ohio Perinatal Quality Collaborative and Ohio Health. In her role as Medical Director of Maternal Fetal Medicine at Ohio Health, she is leading the system efforts to incorporate AIM safety bundles into practice and spending time not just on completing tasks, but emphasizing a culture of safety and quality in all her work. Her care for marginalized patients throughout her career has broadened her lens of equity in the delivery of healthcare. Dr. Prasad, thank you very much for joining us this morning.
Thank you so much, Charlita. I do not have slides, so I'm hoping our group that's enjoying this conversation this morning will indulge that conversation as it is. Obviously, we are among greats when it seems we have advocacy voices in the community like Dr. McDougall, and I am learning that we have a shared experience in our Master's in Public Health. So I went to the University of Michigan as well for my Master's of Public Health. It hurts my soul a little bit to live in Columbus my whole life since my training, but we're working on that still. I actually have a unique interest in viruses from my Master's in Public Health training, and that has sort of stemmed my academic interest in hepatitis C. I actually worked in my public health degree with Hussein Masab, who was one of the pioneers in the H1N1 vaccines and flu vaccine technology. And like, you don't even realize it at the time because you're just a kid and you're just a student, but in retrospect, you see how those building blocks really create your vision and what you're doing. Interestingly, as this COVID issue around pregnancy has come up, and what do we do with pregnant moms and how at risk are they? I reflected that in 2009, I was pregnant with my second baby, and that was the time where we had a big shortage of the H1N1 vaccine. And we were clamoring to try to find the at-risk populations. I actually was part of Governor Strickland's task force and briefing on identifying pregnant women at unique risk for adverse outcomes from respiratory illnesses like the flu. And we gathered together and created that priority for pregnant women to receive that flu vaccine in 2009. And so it's a very interesting sequela now that we're in, that we have this severe respiratory illness where pregnant women have been identified to be at significant risk and of a higher risk population to get really sick from mechanical ventilation and ICU admissions and adverse pregnancy outcomes, but yet we're still hesitant to take on a vaccine. And so I wanted to talk a little bit just about the rationale for vaccines in pregnancy, and then we can dig a little bit into what I know about how the COVID vaccine is specific to those pregnant women. I think you'll hear pregnancy is just another subpopulation of people that's not really well studied. And so when you talk about disparities in general, it's unique. You have disparities within all pregnant women, but pregnant women as a unique population to the general population are also understudied. And sometimes then the knowledge that we are applying to them is limited. And so it almost feels experimental when you don't have sound data to apply then to that specific population. And so we have lots of examples in pregnancy of giving moms vaccinations. We know pregnancy is a time when women get frequent medical examinations, they're engaged in the system. So if there's things that have been missed along the way, we seize that opportunity. We don't feel worried about giving people such vaccines as flu shot or Tdap. We give Tdap commonly. Maybe we can use this moment to bang the drum on that too, because we believe that mom's immune function is something that can actually get spread to baby, pass to baby, and protect a baby in those early weeks of life before a baby can get their own vaccines. And so we try to seize the day both to protect the mom, but also use mom as a vessel to get that immune function to a baby and protect them. We have not given all vaccines. There are some that we absolutely don't. We don't give vaccines to moms who where the vaccine is actually a live virus. So measles, mumps, rubella, we don't do that because those diseases are live inactivated viruses, but there's that small potential that they could transmit the virus to a baby. And those viruses could cause an infection within the baby. And so we don't try to go down that path with those live attenuated viruses, but we're pretty aggressive with the recommendations. And though we always embrace patient autonomy, we all as physicians are like, please take the vaccine, because we think from a public health standpoint and from a mom to baby transfer of immune function, sometimes that's the right thing to do. So we hope that people do it. We don't force anybody to do anything, but we try to encourage them with good information and good science to try to justify those decisions. We have struggled when it comes to COVID and how does all of this work apply to pregnancy. It took a long time to identify that women indeed who were pregnant were a high risk category for having outcomes, and the outcomes that were increased and significant in pregnancy were ICU admissions, ventilation, and death compared to non-pregnant women of reproductive age. So it took a little bit of time to assign that priority to pregnancy, to identify that there was significant maternal risks associated with COVID. Fetal risks, we're not sure. And this is where I think we've all become impatient because we wait for evidence before we make big recommendations, but we all sort of suppose. There's a lot of supposition out there trying to make the best decisions with what we have. And none of us are patient enough to wait for the great evidence. But we all felt this backdrop of like, gosh, are we seeing more preterm labor, more stillborn babies, more evidence of placental issues in moms that had COVID, such that babies weren't growing well, or we had early ruptured membranes or preterm delivery. So those are all things we suppose. I think there's some early observational studies just following women, and we think that there is an increased risk of adverse outcomes in babies as well, whether directly impacting babies from the virus or from the maternal compartment, moms being sick, and how can they support those babies. We don't quite understand exactly why, but we understand that there's probably some underlying risks. As I was sort of on my own journey as a healthcare person, as a mother, and as an advocate for women, I tried to make myself learn about the vaccine and how really is it going to impact us. And because I am not a geneticist, these things all sound really scary when you're like, ooh, it's mRNA, ooh, it's genetics. And I had to peel back to my med school and like, remember, why is this unique and different? And why should I be scared or should I not be scared? And I really felt like I needed to, because I so strongly from my public health background believe in vaccines and communities. I was like, I have to be able to have a voice that can help people understand. And as I understand it, vaccines work because we show your body something foreign. Your body says, hey, I don't like that. I'm going to create an immune response to it. And then, and so when I see it in real life, I'll have my tools ready to go. In other vaccines, we give you that protein, we show you it. Your body's like, oh, thanks for the protein, here it is, and we're going to react to it. With mRNA vaccines, they are able to just give you the little genetic sequence for it. So your body uses its own tools to make that protein, and then it gets rid of that message. It doesn't go into your cells. It doesn't go into what makes you you or change your genetic uptake. It just simply gives you a little message and then it shows it to your body. So it's a very similar theory, just a little bit different package. And so for that reason, I have been a big advocate for doing this vaccine in pregnancy and out of pregnancy, because I can't imagine that there really is an adverse outcome there. I think the questions that are uncertain for pregnant women are, does the vaccine behave similarly? Does it give you the same immune response as a non-pregnant person? Not that I think that there's going to be significant harm to a baby from the vaccine, because if you have that immune function triggered in a mom's body, hopefully we could pass that through the placenta, just like we do in other viruses, and get that protection to a baby. Those things are still unstudied, as you might imagine, but that's, if you take what we know about all the vaccines that we've ever used in pregnancy and apply that to this, we should be on decent footing. I think it is hard. We have, again, there has not been a lot of representation of pregnant women in the ongoing clinical trials. And if you even peel it back a little bit, the first clinical trials that were done on this vaccine they thought they were done sooner than they thought. They thought they were done back last summer. And then they realized that the population was not diverse and inclusive enough. And then they ended up saying, hey, we have to include more people so that this is generalizable work that can apply to everybody and not just this unique population of people. You can imagine might be different from those people that are willing to take an early untested vaccine are probably different than everybody that we encounter. But amongst even the broader group, there was not pregnant women uniquely involved in that testing. And so now we are learning by experience and observation of women that have had the vaccine and either have become pregnant or who were perhaps healthcare workers that have had the vaccine in their pregnancy. And I think Dr. Fauci has said that there's been 20,000 pregnant women actually, or women who have either become pregnant or who are pregnant already and received the vaccine without any major upticks in adverse pregnancy outcomes, and so, or complications that we can see as they believe to be unique from the vaccine. So we are getting confident, we're becoming more confident and be able to say, gosh, what we know seems to translate to this work and this population, but then we are building upon that in a very intentional way. I will also say from what I've learned in my journey is even in the beginning, the vaccines, they think any major adverse outcomes are going to be seen in the first 8 weeks. That's what they've learned from all the other studies. Dr. Paul Offit, who's on the ACIP that makes national recommendations, I've listened to him talk on a ton of occasions, and they suggest we should have seen anything concerning for long term in the first 8 weeks of vaccine administration. And so I think we're learning. I think 8 weeks has passed since we've started, thank goodness. And I think we're learning and getting more confident, which is, I think, the really big point. I think as we move forward, we owe it to ourselves to be inclusive in the populations that we serve. And I think women are higher risk for COVID sequelae. I know women of color are at higher risk for adverse pregnancy outcomes, no matter what the condition. And I feel like it is our job to invite confidence of our patients in however many forums we need to allow questions, allow people to make the right decisions for themselves. We probably won't be able to say, we know tons about you and your specific situation, but how can we create dialogue so you can feel confident in your unique situation to either embrace the vaccine or not? In the beginning, people said we shouldn't give a COVID vaccine to pregnant or lactating women because we didn't have the evidence. And I understand that from a scientific perspective, but it also feels really disparate to say we can't give you a vaccine just because we don't know it and we didn't choose to study it. And that's the reason we don't know, is because we didn't. So this has been a big jumping off point in women's health to say we shouldn't be excluding pregnant women on the basis of pregnancy alone. I think all of our work is around mothers being more than a vessel for their babies, because without a healthy, stable mom, we will not have healthy, stable babies. And if we lose a mom to COVID because she didn't want the vaccine and she's at super high risk for having something happen, we have done no good. So that's my like coffee talk. I'm pretty passionate about this, and I would love to be a resource if it's helpful to any of you. So thank you so much for your time.
Thank you very much, Dr. Prasad. Chris, do we have any questions specifically for Dr. Prasad at this point? I just have one. We haven't studied with, obviously, the Pfizer and Moderna vaccine pregnant women. How about with this new one-shot vaccine, Johnson & Johnson? Has any study been undertaken for pregnant women?
Charlotte, I'm not aware that there is, but I can tell you the Pfizer group has started a placebo-controlled double-blind study of 4,000 pregnant women to look very specifically at how does your immune function go? Is there any, let me tell you, the safety of it, tolerability, and immune function of it. So that is underway. I fear, though, it's just like, it's not going to be timely enough. I feel like we're going to, at this point, again, I don't know how many women would sign up for, if you think you're at risk for a placebo versus a COVID vaccine unknowingly. But I think in the current climate, maybe with the background of infection, I don't know if people are going to be a little bit less scared. I don't know how that will go. I'm just hoping we get timely information so that people can help make decisions. There's a group at Duke Medical Center who's actually, they're pals of mine, Dr. Geeta Swami and Brenna Hughes are sort of leading the charge on infectious disease at ACOG and the Society for MFM, Maternal Fetal Medicine. And at Duke, they are actually just following pragmatically 350 women who have either received Pfizer, Moderna, whatever vaccine they are, and then following those same kind of time points, which ends up being a much more practical way to get good data. It's not going to be blinded or controlled, but we'll at least be able to see what's that impact for those specific things around pregnancy, and hopefully get something that we can wrap our arms around and feel a little bit more confident with.
I'd like to add also,
Sure.
So in development of the vaccines, there were reproductive toxicology studies done in animals, and they did not reveal any increase in risk towards the vaccines to the fetus during pregnancy. So there was some preliminary research done with this in animals.
Yep, thank you, Dr.
For that response. And we'll talk a little bit more about studies and who's been included a little bit later. We're going to have our last speaker, Dr. Jeffrey Maribel. Dr. Maribel is our very own Chief Clinical Officer here at Primary One Health. And he's also the Women's Health and Family Services Director at Columbus Public Health. We share him. He is an obstetrician and gynecologist with over 25 years of experience. He is also an adjunct instructor in obstetrics and gynecology at The Ohio State University and a clinical instructor at Ohio University's Heritage College of Osteopathic Medicine. Dr. Maribel also serves on the board of the Ohio Better Birth Outcomes and was recently appointed to serve on the Mayor's Strategic Planning Committee to reduce racial disparities in infant mortality. Dr. Maribel, thank you very much again for joining us today and lending your expertise. And you can take it away.
Thank you, Charlita. Let me first start by sharing my screen. Okay, I think everyone can see that. And let me go ahead and start the slide presentation. I hope to be able to do that. Okay, here we go. Here we go. Okay. All right. First of all, I do want to thank Dr. McDougall and Dr. Prasad for their presentation. Certainly was very enlightening. And again, I want to thank you for your work and for your contribution in not only pregnancy and treating women with high-risk pregnancy, but certainly your work also with the overall the overall work in trying to improve healthcare for all those that are involved. So let's go ahead and begin. This morning, I'm going to talk to you and give you a brief overview of COVID. Where are we in battling the pandemic? Which groups are most likely to be impacted? And finally, how soon can we get back to normal? So let's start off by talking about COVID. I'm sure all of you know by now, COVID-19 is a viral disease caused by a novel coronavirus that had not been previously seen in humans. It was first identified in Wuhan, China in December of 2019. And when you think about it for a second, it seems like this virus has been with us for many years, but in fact, it's only been 2019 since we've learned about this new coronavirus. And I think because of the devastating impact it has had on all of us, we think that this is something that we've been dealing with for years. But in fact, that has not been the case. As you know, it has been hypothesized that the coronavirus began as a link to a wholesale food market in Wuhan, China, where livestock was sold. And then we know that it spreads through respiratory droplets such as coughing, sneezing, talking, singing, and breathing. In addition to, we know that the main spread is through close contact from person to person, including people who are physically near one another, and specifically within 6 feet. So when you think about where those guidelines came from, those recommendations about making sure that we are at least 6 feet apart, it's from knowing how viruses, and particularly how this virus behave. So when you're within 6 feet, you are at a much greater risk of transmitting the virus to someone else. And equally important, it's important to know that people who are infected but do not show symptoms can also spread the virus to others. And this is one of the reasons why this disease has been so devastating, because for a long period of time, in particular before we instituted mandatory mitigation a mitigation advice is we would have individuals not knowing that they were infected and will go on to infect others, loved ones, their families, mothers, fathers, colleagues, and they would eventually get very sick or even pass away from the disease. So we've learned a lot that within a short period of time that you can have and you do have the ability to acquire this virus and pass it along to others. So globally, let's talk about globally. There has been over 113 million cases of COVID-19 to date, with over 2.5 million deaths. In the United States, we have over 28 million cases of COVID-19. And astonishingly, we have over 510,000 people who have lost their lives from this disease. In the United States, the number of deaths is double than the nearest country, which is Brazil, with respect to the number of people who have perished. So I want us to stop and think about, it's extremely sobering to realize a country of our stature, a country where we have the best access to healthcare in the world, have lost over 500,000 people in just over a year. So let's talk about some of the mitigations that have been put into place to curtail and eventually will go on to defeat this virus. We all know that washing hands is key in helping to slow down the spread of the virus. Not only should you wash your hands once or twice, but you should wash it often. And that is just good hygiene and good practice, particularly those in the medical forum and community where we come into contact with patients, where there may be exchange or come into contact with bodily fluids or secretions. It's key that each and every time that we practice good hand hygiene. Another mitigation that we recommend is covering your mouth or nose if you're coughing or sneezing, using the inner part of your arm to do so. And I know that sounds like common sense, but many individuals still to this day do not make an effort or attempt to really try and minimize the amount of droplets that can be potentially spread by not covering their cough or sneeze. The 6 feet we all know about, again, staying 6 feet or more apart from individuals, and particularly during indoor or group setting, is key in helping to slow the virus. We know that the virus can't travel very far. And so if we just take these steps of keeping our distance, making sure that we respect each other's space, and practicing that on a regular basis, again, that will help us slow down the spread of this virus. And finally, the number one factor, the number one mitigation that we put into place that we know absolutely will affect the spread of this virus is wearing a mask. I know there's been controversies, especially at the beginning when we started to find out that this virus can cause death on a massive scale. A lot of individuals were hesitant to wear a mask. I think the evidence is clear. It's clear that wearing a mask will help protect and prevent the spread of this virus. And there's been talk about double masking in certain situations, which is even more effective, wearing a surgical mask, and on top of that, wearing a cloth mask that may be 2 or 3 layers will afford even greater protection. And even the former director of the CDC said that wearing a mask is more effective than getting the vaccine. So that just tells you how powerful and how important it is that we wear a mask. And even after we're vaccinated, we should continue, at least for now, to mask up. So, as you know, this slide is a little bit outdated, if you can believe that. But actually, there's on the verge of being 3 vaccines that will be available to the general public. The first one is the Pfizer-BioNTech, followed by the Moderna. And as you know, Johnson & Johnson is on the verge of getting approval for emergency use authorization. So let's talk briefly about the 3 vaccines, in fact. So Pfizer vaccine, as you know, it requires 2 doses that's given 21 days apart. It's been shown to be 95% effective. However, the huge disadvantage with the Pfizer vaccine is that it requires ultra cold refrigeration. And that presents a significant amount of problems for many reasons. First of all, not everyone, not every organization, not every hospital, not every health center has access to these ultra cold refrigerations. Secondly, they're expensive. And then thirdly, when you talk about transporting from point A to point B, you have to make sure that the virus that the vaccine is maintained under these extreme cold conditions. If not, then the vaccine could be rendered useless and you will not be able to administer, which obviously is the end goal with these vaccines. So that's the summary with Pfizer. The Moderna vaccine is interesting. Moderna also requires 2 doses. They're given a little bit further apart, 28 instead of 21 days between doses. It has been shown to be 94% effective, which is pretty much the same as Pfizer. The nice part about Moderna, however, is that it doesn't require the ultra cold refrigeration as Pfizer does. And I might add also that recently, just a day or 2 ago, I've heard that Pfizer is now suggesting that we would be able to transport and store the vaccines without having to use ultra cold refrigeration, which would be huge, which would be a significant deal as we try and administer and increase the supply chain. I do want to talk a moment. I know I don't have this on the slide, but about the Johnson & Johnson vaccine, because I think out of all the vaccines, this truly is going to make the biggest difference. And the reason why I believe that to be the case is, number one, it is a 1-dose vaccine. You're one and done. So we don't have to worry about making sure that individuals who receive the first dose are tracked and make sure that they are available and they come back to receive the second dose. So obviously there's going to be a higher rate of compliance with that respect. The other beauty about the Moderna vaccine, about the Johnson & Johnson vaccine is that it can be stored in regular refrigeration. It doesn't require any sort of ultra cold temperature in order for the vaccine to be useful. So that will eliminate a huge problem that we face with the other 2 vaccines, and with respect to transport, and with respect to the fact that there's going to be a 3rd vaccine that's going to be available for people to be immunized with is a huge deal. And I think another case in point that really is going to make this vaccine tremendously helpful is that it has been shown, the data has shown that this vaccine prevented hospitalization and death 100% of the time. Based on the studies that were performed. And when you think about it at the end of the day, because I know there's some folks who are kind of concerned about the Johnson & Johnson vaccine not having as higher a percentage versus the Pfizer and the Moderna. I believe the Johnson & Johnson vaccine overall was shown to be 72% effective. But again, when you factor in those who did not end up going to the hospital, end up having to be admitted to the ICU, or end up dying, the Johnson & Johnson turned out to be 100% effective. And quite frankly, at the end of the day, that's what it's about, right? Saving lives. And the Johnson & Johnson vaccine has been proven, has been shown to do just that. So I think we have 3 excellent vaccines that are now available, and I hope we can get them in people's arms sooner rather than later. Let's talk about vaccine distribution for a couple of moments. In the US, more than 64 million doses have been given. That's an average of 1.37 million doses administered per day. And at this rate, it is estimated that it would take about 10 months to cover 75% of the US population and reach what we call herd immunity. And that's key, because if we're ever going to get back to being quote unquote normal, if we're ever going to get back to pre-COVID way of life, we need folks to get the vaccine. And we need to achieve that 75% before we can think about doing some of the things, having some of these social events, gathering on a large scale like we did pre-COVID. So I would be remiss if I didn't talk about not all vaccine distributions are created equal. As of now, 63% of Caucasian and whites have received the vaccine, 9% of Hispanics have received, 6% of the African-American patient population have received the vaccine, and then the rest were made up of 5% Asian, 2% American Indian, or Alaskan Native. Interesting enough, and I think Dr. McDougall has spoken about this as well, there's a significant percentage of the patient population who refuse to reveal what their ethnicity is. They decline when asked of their ethnic background. So part of that has to stem from the historical nature of how vaccines were administered, how vaccines were created, and the impact that it has had disproportionately on certain communities versus others. In Ohio, interesting enough, African Americans make up 18% of the population, but only 5% have received the vaccine. So we have a lot of work to do. We have to continue to outreach, continue to make people aware that this vaccine is safe, it's effective. We're getting the vaccine as well, so that until we can build up enough confidence, we're going to continue to see these numbers lag behind other ethnic groups. Just a moment, I just want to take a moment to talk about variants. As you know, variants certainly has made the news recently, and for good reason. But first and foremost, we should know that variants are not uncommon when it comes to viruses. Viruses are changing all the time. They're changing their configuration, morphology, because they're trying to survive. So when there is a vaccine, for example, that's developed, the virus will recognize that and try and tweak its makeup in order to render the vaccine not as effective. Obviously, with the variant, there's the potential to be more contagious, and as a result, to end up with more people dying if exposed to the variants. Actually, there's three, but the two most talked about are the variants from the United Kingdom and South Africa. There's also a variant out of Brazil that's getting a lot of play as well. All of these variants have been detected in the United States, which obviously is a concern. However, the good news is that all three vaccines, including the Johnson & Johnson, have been shown to be effective against the variants. And in fact, what is being thought of right now, I know there's been talk about maybe having a third shot or a booster, if you will, for Moderna and for Pfizer in order to cover those variants that may not necessarily be covered in the original vaccine. And of course, Johnson & Johnson. In fact, Johnson & Johnson study had a high success rate when it came to immunization against the variants from South Africa and Great Britain. So I want to leave you with some FAQs. I have folks ask me all the time about COVID-19, and these were some of the more frequent questions that were posed to me. Number one was, can I get COVID-19 after receiving the vaccine? So the short answer is no, but it's not that simple. But for the most part, if you've received the COVID vaccine, and for Pfizer and Moderna, you received both doses, not just one, that it is unlikely for you to get COVID after receiving the vaccine, and then obviously after waiting the 2-week period of time from the second dose to be fully what we call immunized. Now, there have been reported cases of individuals who got the vaccine and then ended up getting COVID, but we don't think it was because the vaccine didn't work. We just think the timing of when they received the vaccines versus being exposed to COVID wasn't wide enough in order for that individual to be fully protected, and therefore the individual ended up getting COVID. So the short answer is unlikely to contract COVID-19 after receiving the vaccine after an appropriate amount of time have passed. Number 2, do I still need to wear a mask once I get vaccinated? Absolutely yes. From now until the near future or beyond, we still need to mask up. We still need to wear a mask. As I mentioned earlier, the mask has been deemed to be certainly, if not just as effective, more effective than the vaccine itself. So if you have the vaccine, it makes sense to continue to wear the mask until at least we develop the herd immunity. And then I think that you'll probably see a backing off from that. But I think moving forward, that just may be par for the course, where if individuals are sick, or if we think that we may be at risk for some sort of respiratory exposure, it may not be, or we're out in the public in large gatherings, it may not be a bad idea in general, post-pandemic, to wear a mask. Will the current vaccine protect me from the variants? Well, I just mentioned the 3 vaccines, and I'm including Johnson & Johnson, does seem to offer some protection against the variants, and that's the good news. And the companies are continuing to work to make sure that any variants that are identified will be protected against the current vaccines. Will I need to get the shot every year like the flu shot? We don't know. We don't know yet. It may be a situation where we might have to get a shot every year. I think the jury is still out. We're still collecting data to see whether or not, to see how long we're immune with the vaccine and how long the immunity will last, but it may very well be that this is something that we might have to get on an annual basis. And secondarily, we might have to also, which leads me to the last question about the choice of vaccine, having a choice of what vaccine that I'm going to receive and when I can get it. Well, right now, you don't have a choice. I mean, there aren't enough vaccines around for one to pick and choose. They want one over the other. So my recommendation would be whatever vaccine is available, please go ahead and use it. Now, there will come a point in time where the supply will outweigh the demand. And when that happens, you may very well have a choice. And there may be some vaccines that may be better suited to treat certain populations or groups. So for example, the elderly with underlying chronic conditions, maybe one vaccine has a more favorable result in treating those that specific group. So there may come a point in time where one vaccine will be preferred over the other. But as of right now, whatever vaccine is made available to you, and when it's your time to get it, you should take that vaccine no matter which type it is. So I hope I was able to shed some light this morning about COVID-19 and what we all can do to bring this pandemic finally to an end. Thank you.
Thank you. Thank you very much, Dr. Maribel. And we really appreciate your taking the time to go through likely questions, frequently asked questions, because I know each of the physicians on the phone or on the YouTube today have received those questions and more. And we really want to hear from those that are part of today's session, our community health advocacy breakfast forum. I think we're having a little trouble with our chat box. I've asked Chris on several occasions and she didn't have any, and that's because I've gotten texts that people are having difficulty, that it's not operating. So I just want everyone to know that that's the reason you haven't been able to ask your question in the chat box. So I'm going to ask a few questions, and hopefully our IT guru will be able to get it fixed. If not, we will certainly post this YouTube video on our YouTube channel, and we will send out the link to everyone that has participated. I do have a couple of questions. First of all, Dr. McDougall, you talked about the 4 pillars in the African American community. How can we use those pillars to disseminate information to African American communities, and if these kinds of pillars operate similarly in other communities?
Yes, very good question. So right here in Columbus, we have Links Incorporated. I know we're working with them on a national basis, President Jeffrey Leonard, and also there's a planned event with me working with them on an event, I think coming up sometime in March with our own local Links Incorporated here. I know I was also contacted by the Jack and Jill Foundation of America. That's another group that's not only national, but local. And then some of our community-based organizations and churches and clergy. I know Bishop Timothy Wright was on another town hall that I participated in. So I think reaching out and collaborating with clergy leadership across Columbus, that's another avenue of reaching out to the community and partnering with other trusted messengers to make this vaccine more available and to also help offset vaccine hesitancy. So those are just some of the examples I can think of top of mind.
Thank you very much. And I do know that you and I participated in the Phi Beta Sigma organizations, or the fraternity, their town hall on COVID-19. So fraternities and sororities, I know that both the AKAs and the Deltas have had, and the other sororities have had listening sessions, educational sessions. But we talked about how we get the message out to the communities in a broader way. And certainly we have African American and communities of color who have news journals, newspapers, radio, and in some cases television are other ways to attract the audiences that are disproportionately impacted, but also trusted sources in the community. I know I write for one, the Columbus Dayton African American News Journal, that has the ability to reach thousands of people within Central Ohio, both Dayton and Columbus. And it's a way for us to make sure that information, accurate information, is being shared, whether we're talking about vaccine locations or testing locations, or whether we're talking about information on what COVID-19 is and is not. Dr. Maribel and Dr. Prasad, other ideas about how we get this information out to communities? And then I've got a question from someone who texted a question to me. We've got some very important people who are on the call, and I want to note that Angela Dawson, the director of the Ohio Commission on Minority Health, is on the call, and I will share her question. And then I know our Franklin County Public Health Commissioner, Joe Mazzola, is on the call, and he's been a partner with Primary One Health, not only in testing, but also in vaccinating the populations throughout Franklin County. So if either one of you want to share any other ideas about how we get accurate information out besides these kinds of YouTube, Facebook, WebEx, etc.
I do think there is power in social media in these kind of message. And I think the interesting thing is how relatively powerful the alternative messages have been. And so a lot of things we have to not only build confidence around what we have, but then undo perhaps some mistrust that maybe we are like at a starting line that isn't even a normal starting line for us in disseminating information. I am not a great social. I'm too old for real good social media, but I think there is power in those influencing people and voices and Instagram stories and whatnot. People just do rolling things on the daily, and once people pick up that following, you have a platform that goes and goes. I think we probably don't embrace those things enough, and we rely on people just to trust us. We've got training. You should just believe what we say, but it's so much deeper than that. And really acknowledging all of those people of influence, whatever degrees or not, or after their name. I think, as you identify, I think there's probably niches within the communities you already identified.
Yeah, I wholeheartedly agree. I think that we have to use whatever available social media platforms that we have, and certainly having a strong IT department can help us facilitate having access and disseminating information along those platforms. I also think that churches, particularly those vulnerable groups, are extremely important to have the information available so that information can be shared with their congregation. Churches have historically been a place of trust, a place of reliability, a place of comfort. And so if we can make sure the information is available at places where people naturally gravitate to, have a connection with, I think we can get the information out there more effectively. It's going to be a matter of trust, who they're hearing information from, whether or not there's a sense of credibility, whoever the messenger may be. And that's why I do think that we have to lead, not only talk about how important the vaccine is and how safe it is, but we need to lead by example. We have to say ourselves that, listen, we received the vaccine and we're doing okay by it. And I think once we kind of get the word out there to individuals that it is something that is safe, that you can trust the information that's being told to you, then I think we'll see better results. But utilizing all social media platforms is certainly a key to get to disseminating the information and getting it out there.
Thank you very much, Dr. Maribel. I understand that the chat box is working again. I'm going to take one of the questions that I received through a text from Director Angela Dawson, and she wanted to know, and I think this probably goes to Dr. McDougall, why is it important to consider life expectancy on racial and ethnic populations in the age-based distribution plan?
Thank you for that very important question. So we talk about systemic racism, we talk about structural racism, and sometimes the disparate effects are related to how we select people to be vaccinated, and then even going back to being diagnosed with COVID-19, there was a screening questionnaire that people had to answer, and before they got to the next stage. And what we found that European Americans were passing the test and getting to that next phase more often than people of color. So so this makes, so I'm gonna answer the question, it connects to a lot of things. Let me just answer the question. So when you look at, we don't live as long. I showed on that depiction about how COVID-19 was decreasing life expectancy. So on average, African Americans don't live as long as European Americans. So if the methodology used to select who gets vaccinated doesn't account for that, you have a whole cohort of people who are not 70. There's not as many people who are 75. There are not as many people who are 65. So the design of methods to select populations needs to be tailored to who's dying, who's being hospitalized. So as we state in the public health manifesto, there needs to be a priority placed on those communities suffering most. So on the face value, it seems like it's a fair way to do things. Every 75 and 65 is just fair for everybody. So that's the difference between being equal and equity. So that's the essence of the question and my answer. Hopefully that was helpful.
Thank you very much, Dr. McDougall. I think your bringing up life expectancy has an impact on so many other areas of our life. And as you said, it implies that it's fair because it's an age. We're just going to allow those who are 80 and over, and now 75 and over, and now at this point in time, 65 and over. However, if you don't live to that point in time, your populations are disproportionately going to be impacted. And I think about that as you were talking. My dad died of a massive heart attack at 48. So it would have never gotten down to him, even though he had had a stroke at 38, a massive stroke in the carotid artery. So those kinds of issues that impact communities of color. Another example, Social Security. Can you think about how many people in your family have never lived to even receive the first Social Security check? Disproportionately, communities of color are paying for others to receive Social Security because we don't get to receive it. My dad didn't get to receive it, and my mom didn't get to receive his. So those are the issues that we have to look at systemically as a country. And I think COVID does bring up the opportunity. Chris, I know you have some more questions now.
The first one I have is, what are your thoughts on vaccinating kids?
Anyone can take that one.
Yes, I'd like to take it. So there's a descending method that's being used for that. So for the Pfizer now it's to 16, and I believe there's doing studies now to age 12. So the way they conduct those studies is descending. So 16, 12, and they'll keep going until I think they said like 2 months of age. So that's the plan in regards to immunizing children and doing the phase 3 clinical trials to look for serious adverse events. So that's happening.
Anyone else want to respond before we move on to the next question?
Well, I mean, I think it's certainly would be it would be great if children are able to receive the vaccine. I think we still need to conduct studies, evaluate the data to make sure that the vaccine will be safe. I mean, we do know that children in general don't seem to get infected or have the same impact as older individuals. So certainly that's good to know. But as far as whether or not the vaccine should be administered, we just don't have the data right now. So I think we're going to have to wait until more information becomes available.
I agree with Dr. Maribel, and I think that we have to be careful about that in terms of goalpost moving for schools to open and things like that, and remind ourselves what we were dealing with in the first place was cohorting people so that elderly, vulnerable people weren't overwhelming hospitals and whatnot. If the pediatric population, yes, super important. My understanding, similar to Dr. Maribel's, that they don't get as ill as older people, but keeping them to be safe so they don't infect more vulnerable folks is the goal. Not to necessarily vaccinate all kids before they could go back to school. Just anecdotally, my 11-year-old had COVID right after the holidays, and I would have sent her to school in any other year because I'm a doctor. She did fine. She had a runny nose and was okay, but because we're in this climate, we test her, of course, and we did all those things. But my experience with her in face-to-face school is that those kids, even when they pass it around, they aren't significantly ill.
So I do one caveat. So there are children who are becoming ill and developing a Kawasaki illness type disease with inflammation of the heart and fast inflammation of your vessels. So it's less likely, but there are concerns concerning COVID and the health of the pediatric age population.
Thank you all very much for that. Chris, do we have another question?
I'm not seeing any more, so I think the chat appeared a little late too. So I'm not.
I'm going to encourage everyone to, if you have a question, to please put it in the chat box. I do have another question for each of you. We've talked about the populations that have already been given the opportunity to receive the COVID-19 vaccine. And we've talked about the disproportionate number of African Americans who have had access to the vaccines. We've talked about social media and certainly cell phones and internet capabilities. I believe, and I wanted your opinions, I believe that we've relied too much on the electronic or the intranet as a way to connect people to vaccines, that we need to ensure that we have multiple ways, particularly for older adults and communities that are economically challenged who may not have regular internet services, other ways of reaching them so that communities of color disproportionately poor or are experiencing poverty, that they can get in and get the vaccine without having to go online. Your thoughts?
So very good point. And I'm coining a term called the mom test. So people in their, say, 40s or above ask the question, was your mother able to navigate the system to get access to the COVID-19 vaccine? And I know in my case, it's been difficult. And so in speaking to Jamie Carmichael from the Ohio Department of Health, the governor's office, she was also recommending that our older persons reach out to the Ohio area on aging to be a resource to help with that. And then apparently too, in Columbus, there's a 211 number one can call for help. And then Charlita, you make a very good point about relying too much on social media, high-tech electronic means of communications. And that's where we also have to engage with our community-based organizations. And I'm thinking, especially for those communities that have limited English proficiency, such as our Somali population, our Nepali population. We have huge Somali and Nepali refugee populations here in Columbus and a growing Latinx population here. So I think we need to have culturally sensitive, multilingual messages, just as we spoke to back in April in the manifesto, and to complement these other higher tech means of communication.
Dr. Prasad or Dr. Maribel, any additional comments?
Oh, I agree with Dr. McDougall. I think that we have to provide resources for greater outreach where we can physically have community outreach workers to go into those communities and reach our elderly and reach those who may not have access to some of the social media. platforms and walk them through the process. And Dr. McDougall is absolutely right. We have so many people who live in our communities where English is not their primary language, and we have to make sure that we provide the necessary language services so that they can understand and be able to participate in signing up for the vaccine, understanding how the vaccine works, dispelling some of the myths that is surrounding the COVID-19 vaccine as well. So until we get really serious about dedicating and having resources to go to where patients are, rather than relying them necessarily to come to us, we'll continue to have this gap of services to those who are vulnerable and who need them the most.
On that point about social media and certainly the electronic technology, most people, regardless of income, have a cell phone. And most of the cell phones today are smartphones, may not have the data plan where you have unlimited internet services. But if you can use the phone to text, and that might be one way of teaching older adults or having younger members of the family text. Primary One Health has the opportunity for people to schedule their appointments by texting the word vaccine, VACCINE, to a phone number, 614-502-5329. And whether it's that older adult or whether it's the niece, nephew, child of that older adult, they can look for the appointment that meets the needs of that individual. And that's a way of getting in and getting the appointment, but also not having to have the internet services. So that's, one way of doing it. And then certainly using the telephone. We do robocalls to our patients. We were trying to get as many of our 80 and above when we opened up vaccines as possible. Primary One Health had 671 people over the age of 80. We only had in that first go round about 200 vaccines. So, it's encouraging people to go on and text vaccine to that number, but also to make sure that people outside of our federally qualified health center don't grab up all the appointments. You want to make sure that your patients who are disproportionately, we're proud to say, people of color. About 37% of our patients are African American. We have about 20% that are Latinx, and Somali are included in that African American. And then we have a very large Bhutanese Nepali population. So we want to make sure, and we're proud of that, more than a third of our patients speak a language other than English as a primary language. And so that's very important for us to make sure that we have diverse ways of communicating and that we're reaching people regardless of what the mode is to get them connected to the vaccine. On that point, and Dr. McDougall, you made a point earlier on, and I think someone else raised it as well, about the number of people who aren't identifying their race or ethnicity and what that means. Can you and Dr. Prasad and Dr. Maribel share why it's important to have race, ethnicity checked?
So very good point. Actually, I was on another town hall yesterday with Commissioner Mashika Roberts, and she told how with an event for vaccinations that they held, that even though looking in the audience, it looked as though there was about 75% African Americans getting the vaccines. And when they looked at the data at the end of the day, very few had volunteered that information. So strategically, the next event that they held, she had people with very good people skills and communication skills and who were able to relate to the Black community. And then 75% of those participants actually self-identified as being Black. So I think part of this is how one asks the question and being culturally sensitive in that communication. So that's just, I think, a perfect example of what can happen just based on who and how the question is answered, and we need to be counted. So so that's very important, because so we can keep track of these resources. So thank you for bringing that point up, and I think Dr. Maribel had actually mentioned that initially, and it's very important.
I also think it's important to understand the population you serve very specifically, because in change management, you can't make change without data. And I am not one to believe that if you take your whole population and have interventions that are targeted at that population, that it's not, that we need to challenge ourselves to be nuanced about our interventions and tailor to the populations we serve. And in absence of demographic data, we can't do that reliably. And it's presumptive to think that, oh, the interventions that work for this community is going to be the same as that community. And I think we have to just become more savvy in acknowledging the risks associated with the communities of color, and just saying that, talking to people very frankly about that. I talk to my patients now much more reliably, especially if they're on the cusp of like overt medical issue, like race is a risk factor, and how do we incorporate that into medical decision making, and trying to make that conversation comfortable for everybody. So we're working on, inclusion training and diversity training, but it's not until you have the conversations in that little world that's easy. But when you have to sit down and embrace it, that's a bigger deal. And so I think the data is absolutely necessary to make appropriate change rather than presumptive change.
Thank you. Dr. Maribel?
Yeah, I wholeheartedly agree. I think that if you're going to have those discussions, which you absolutely need to have them, because it creates buy-in, and also you can it creates reassurance that what you're telling them is credible. You have to have the supporting data to back it up. So it's one thing for you to say, just go ahead and do this because I'm telling you so. It's another thing to make sure that you have the information that they can review, that they can look at, that you can sit down and talk to them about, to let them know what you're telling them is true. For so long, many patients, many of us living in the community have been given information that has been less than truthful, and that has had an impact. And so we're less likely now to believe something that we hear down the road. So we do need to make sure that we have information to support what we're saying. And I think if we do that, we can begin to slowly peel back and slowly break down some of those barriers and defenses. And we can get folks to, in this case, accept the vaccine in high numbers.
Well, I appreciate each and every one of you for being on today's quarterly Community Health Advocacy Forum. And we do these quarterly. The next one will be held on May 22nd. And I was reading the newspaper this morning, and I'd had a conversation with a colleague of mine recently about the overwhelming homicides in Columbus and Franklin County, and particularly amongst African American men. And the article in this morning's paper was very clear. Homicide is a public health crisis. It needs to be stood up as a public health crisis if we're going to attack it and change the trajectory of African Americans in this community. So our next forum will be focused on homicide as a public health crisis. And I'm sure Director Dawson and certainly former State Senator Ray Miller will be happy, because the Ohio Commission on Minority Health and its predecessor, the Task Force on Black and Minority Health, lifted up homicide as one of the health conditions that was to be addressed in the state of Ohio. That was back in the mid 80s. Here we are at 2021, and it's only gotten worse. So May 22nd, homicide as a public health crisis, and we will identify our speakers. I also have another open enrollment identification. Open enrollment has started for the Market Exchange and Medicaid. You have until May 15th to sign up. We have certified application counselors who can get you enrolled in the insurance that best meets your needs. All you have to do is call 614-620-8088. And then finally, we are doing vaccine administration at 5 locations, 5 of Primary One Health's locations. You can text vaccine to 614-502-5329, or you can call 614-645-5500. I thank everyone for being on today's quarterly community health forum, and I want you all to have a safe and wonderful weekend. Thank you.
Thank you.